Thanks, I'm Laura Adams from the Rhode Island Quality Institute. Quickly take you through sort of the same questions that my colleagues have responded to, sort of set the stage for things. We own and operate Current Care, the state's statewide HIE. It's the officially designated one from the state. We were a beacon community, one of 17 others across the country through ONC, and we served as Rhode Island's Regional Extension Center. We're now also one of the practice transformation networks out of the Transforming Clinical Practice Initiative of CMS. And we entered into those sort of arrangements because we felt that if we could pull in practice transformation, there's a way to get your services and products adopted if you're part of the transformation effort. And then we began to realize that we could do so much more by being in the office of specialists. For example, our TCPI program is 1,500 providers. We have about 1,200 of them signed up now, and we have about 80% of them are specialists, so far been untouched by our health information exchange kind of work and our work to transform practices. So we're excited about bringing in that sector. We own and operate the state's statewide common provider directory, which will go live. We've treated it just like an HIE, so it has these data feeds coming in from the single source of truth for licensure, for example, from the Rhode Island Department of Licensure. We have the source of truth for lifespan physicians coming from Lifespan, and all of those data feeds come in and automatically populate and update. Our largest integrated delivery network CEO at our board meeting said, wow, I think I've got 7 of those provider directories going on in my organization. They're all out of date, they're all expensive, they're all pain in the rear to keep updated. If you guys can crack the nut on that, you've really done something amazing. So we've worked with InterSystems to do that. They're our HIE vendor as well. That product has probably been one of the most eagerly anticipated of anything we've done in Rhode Island. We are a provider of HIE services, including end-to-end interoperability, meaning that our systems, you don't have to leave your Epic system at Care New England or Lifespan. You just hit a button and it comes up, and then you can, of course, extract the standardized data and pull it into Epic if you so choose. Don't have to. But that's also true of Athena and NextGen in the state. Not so much, you can view it in NextGen. I don't think that we have the extraction capability, but it's probably soon to come. We do a hospital alert service that doesn't require, we're famous for having done a very strict opt-in policy because we wanted to be able to upload substance abuse and alcohol treatment information, but we also know that there are HIPAA laws that if a provider says you can have my patient's data coming out of my EHR, we don't need a consent for that through Current Care. It's the viewing that has to be governed by the Current Care consent. We have real-time care management dashboards now so that we can alert every provider in the state every time they go in and out of an ED in our state or a hospital. We can do that aggregated so they can see it on a screen, and it real-time updates them that your patient has just gone into an ED. Here, it'll tell you whether it's your congestive heart failure patient who is having another episode, or whether they've just cut their finger chopping carrots, and you can turn your attention elsewhere as a nurse care manager. Just that information alone was about an hour and a half if they ever found out that you were in the hospital. So we think that that's a huge advance on the quadruple aim, which is to improve the experience of providers as well as better health care, and lower costs. We do a lot of analytics now and quality reporting and data for quality improvement. This is another thing when we pull in TCPI, so we're out there working with specialists to improve their work out there. We can begin to employ things like practice pattern variation analysis, which we think that of all exposed data, accountable data, when peers are accountable to each other, we think that's the most pervasive and strongest tool for behavior changes, where people have contextual information about their own behavior. And so they can see sort of how many tests they're ordering, their quality vis-a-vis that of their peers. All that's being made capable by our centralized repository. Our data for research now, Brown has discovered it, I'll talk about that in a minute. And then Current Care for me, we just decided we just need to turn all this toward a consumer and let that be their PHR, because it aggregates data across geographic, proprietary, and payer boundaries. Somebody can be, in Blue Cross today and Medicare tomorrow, Medicaid the next day, homeless the next day without insurance of any kind. None of that stops the data flow. It comes in across all of those. You can be in a competing system, none of that stops the data flow in Rhode Island. So we've got ADT feeds coming in from all the hospitals. We have Butler Hospital coming on this year, and the VA also this year. We won't have an ADT feed, but we'll have a CCD from the VA. We have about 95% of all lab results, the actual clinical results, sit in our repository and flow in on a continuous basis. Same is true for about 95% of all medication histories coming from the commercial pharmacies. Physician offices, we're lifting CCDs out of all sorts of physician offices across the state. We have radiology reports and behavioral medicine information coming in. EKGs, information you can be in a Minute Clinic anywhere in the nation. If you're enrolled in Current Care in Rhode Island, your data flows right straight into your repository in Current Care. The LT packs are coming in on a $2.7 million grant that we got last fall. So once we pull all that into the central repository, we're able to do Current Care alerts, that alerting function. By the way, we got to thinking, if we can alert any provider in the state of Rhode Island, why can't we alert the daughter in Pennsylvania if her mom falls and goes into an ED? Why can't we alert the person who's got a partner that is a domestic abuser and she wants her sister to know if she ends up in the hospital or ED again? She can't really text her on the phone because he monitors her phone, but we can certainly send an alert to her sister, lets her know you're in the ED right now. So we think there's just an enormous capacity for all of this. The Current Care Viewer is, as we've gotten out there and started to work with specialists, there are 5 phases of transformation in TCPI. We think it's unfortunate there isn't a phase 0 because we have among our specialists people who've said to us, you know, we're waiting for the last minute to adopt an EHR. I think the last minute is already gone. So we have some that are really, really behind that we have to work on. So they don't even need anything but an EHR or actually an internet connection to be able to see their patient's data in Current Care from other places. The provider directory, the Current Care for me, and the analytics. I mentioned that we were the first statewide HIE in the nation to be able to upload substance abuse and alcohol treatment information. That comes straight out of our opt-in. It's just a picture of our by the way, that system allows you to look at aggregate too. It'll tell you all the other places that if the patient comes into the ED, it'll show you the last few places that the patient has actually been. So you can see that they visited 3 other EDs in that same week. They will let you know how many times that patient has been hospitalized in the last 6 months, 3 months, whatever time frame you'd like to look at. For this one, we know that those alerts work. You're 22% less likely to be readmitted to an ED if you get our alerts, and that's now over a very long period of time. You're 12% less likely to be hospitalized if you get an alert. That's just one service that we do out of our HIE. If you extrapolate that for Rhode Island, right now it's a $4 million. Actually, we've been told that that's quite a low estimate by our insurers. They think it should be closer to $9 million. And we've calculated the $22 million extrapolation reduction. They've said it's something more along the lines of $44 million. It's just one thing that we do. That's just on the hospital readmits. Brown has discovered it, so we were a centerpiece for their NRH grant, the IDEA CTR, that's the Institutional Development Award, a program infrastructure for clinical and translational research. They put in the application, no comparable high penetration population-based health resource anywhere, and with that kind of data in it. You can see all the things. They've embedded the data analyst that will be happening at the Quality Institute, and in their bioinformatics core, they've listed us there for both the health information exchange and our data and analytics system off of that big. You know, we can do predictive modeling, and we got another grant, a $500,000 grant from the Rhode Island Foundation to do that on top. But we really feel like that your predictive modeling is only as good as the database upon which you're doing that predictive modeling. And so for ours coming across all those different systems, we think it's going to be phenomenal. Portal, we've done the portal. We're doing it in pilot phase right now, but we also agree with the panelists earlier that nobody wakes up and says, I'd kill for a portal. You know, nobody. So we are doing things like a My Meds app where you can tap and get your meds anywhere in the world. The other thing that we think is that there are just going to be so many other permutations of how people want their data, use their data. We're also cognizant of wearables and the idea that you know, that these things just get generated, and every time you go to an Appapalooza event, I love to go to these things because the entrepreneurs are up there, they're spitting all over the microphone, they're so excited, and they're saying the coolest thing about our app or whatever, it can port the data directly to your doctor. You know, just like was said on the panel, the doctors look suicidal when you say that. It's like, you've got to be kidding. Well, I'm thinking, you know, if you port the data to us as the HIE, you can set up the parameters. So if you want to do a Bluetooth scale, you know, pad on the floor for that elderly patient with congestive heart failure. They can step on the scale, and then you can Bluetooth that data up to the Quality Institute. We'll monitor it for you 27/365. We'll let you know if the patient's gained 7 pounds in 2 days, and then if they have, we'll send out one of those alerts to your nurse care manager. You can talk with the patient on Friday, and that patient will be home with their family instead of drowning in their own fluids in one of our EDs. So we really feel like that the centralized hub is also a place to take in all of that data and again aggregate it so that we can do better and better and better predictive modeling on it. We're looking at claims data, which we don't currently have, and I'll show you why in a moment, but we're working with a very large national presence in our state, a national insurer, to do pre-adjudicated claims, because we know that it's going to be forever before we connect to all of you the way that we've connected to Rhode Island. So we want to know if they've been up to Mass General and had a brain scan so we don't repeat it in Rhode Island. At the very least, we want to be able to get the claim that was filed for that Rhode Island patient that lets us know that that happened. We also think we can do far more, aggressive predictive modeling if we've got claims associated with that. So the last missing piece of all of this is certainly the consumer supplied data. And when I think about that comprehensive record, patient supplied data is going to be absolutely essential. Now, I don't want just the written advance directive. What I really want is I want the iPad video that was taken at Thanksgiving, where everybody sat around Mom, and the question was asked, Mom, what do you want your end-of-life care to look like? What do you want? How do you want that to happen? We've been encouraged to have those conversations. And once we have them, then I think that if we can have the video there, and then here's the daughter who doesn't remember exactly what Mom said, well, there you are in the video sitting next to Mom. I think over time, as we start to really personalize this, I know that when I had breast cancer, I wanted the picture of my son up there because I wanted everybody to understand that I wasn't fighting breast cancer necessarily for myself, but I wanted this 11-year-old boy who loves Gillette Stadium, by the way, big time. He's just dying that I'm here this morning. I wanted him to know that, everybody to know we were fighting for that child to have a mother. That was the goal for my care, for that breast cancer care. So the vision for the future is we want to continue support for improving the quality, safety, and value of the system. So we want to definitely go in there and support providers as they start to transform under MACRA. And I travel a lot and talk about what we're doing in Rhode Island. I was in a bookstore, and I think it was Michigan, and a book jumped off the shelf at me. It was called Physician Suicide Letters. And I just felt like I had to read it because it's just reaching a pitch that I'm hearing all across the country at how unbelievably daunting this is to them. They need all the help we can get. Everything we do in Rhode Island, we try to design as one to ease the burden. Care coordination and waste reduction, intelligent alerts. There's no reason why we can't tell a nurse care manager now, your patient went in the hospital on this class of drugs, they came out on the same one. By the way, there are 2 different brand names. So one's a red pill, one's a blue pill. Somebody better make sure that patient understands, don't take both of those because it's the same pill. That's the notion of intelligent alerts, and we can begin to do that for those that want those kinds of alerts. Continued support for integration, behavioral and physical. The pre-adjudicated claims, predictive modeling, practice pattern variation analysis. We think with our TCPI program, and we can get a group of ED physicians in Rhode Island together with that group of orthopedics. We heard our ED physicians say, we'd love to reduce imaging because we know we do a lot of unnecessary imaging. You know why we do it? Our colleagues from orthopedics tell us they'd like to have this test run, and we know that it's probably not necessary. We do it anyway. If we can start to give that contextual information, it'll be great. Contributing to the public health priorities, the opioid crisis, pandemic, bioterrorism, all of that, and more big data research. Current care for me, we want to bring in social determinants of health, the magnificent 7 questions that John Wasson has developed at Dartmouth. Phenomenal. Just a few questions that we need to be asking our patients on a consistent basis so it adds to that conveyor belt of information. Those data questions include things like, do you think your medications are making you sick? Just things like that, and bringing in social determinants of health, and then applying things like Prochaska's change model to tell a provider that this patient is in stage 2 of their ability to change and quit smoking. So don't talk to them as if they're in pre-contemplation. They're not ready for having this kind of conversation. Scroll over this and we'll tell you what words will work with a patient who's in that stage of transformation. We have a couple of challenges. We have a 2008 Rhode Island HIE Act that ratcheted things down really tightly. Consumers cannot yet direct their family members to get these alerts until we change the law, but it was voted out of the House committee recently, and it's going to the House floor tonight. It's coming out of the Senate. We have high hopes for that. Health plans couldn't get access because they tied it down before ACA because you didn't want your health plan to have access to your data so that they could maybe decide not to insure you because you had a pre-existing condition. That's all a thing of the past. We actually have a Healthcare Confidentiality Act that doesn't let our insurers send data into our HIE. We think that this, again, is going to be rectified this week. I do want to say that, shameless plug, we have an opening for our HIE director. If you'd like to think about how to take us into the future, we'd like to talk to you. We want to form an advisory committee because we want to be disrupted. We talked with Patient Ping this last week. They're a company that has done just amazing things to come in and do this alerting, different than we do. They've got 20 Google developers working with them. Just pretty impressive kind of work. We want to be disrupted in that way. We want you to talk to us and say, we have a better way to do what you're doing there, because I don't want to be doing the same thing in the next 3 to 5 years, even the next 2 years that I'm doing today. I want it to look entirely differently. So we're going to form an advisory committee of VC. We're going to, for people who are entrepreneurs to come in and we can say, what kind of playground can we create here in Rhode Island? Because we can bring the entire system to bear for you. Our board of directors is the CEOs of every major delivery system leader in the state. All the health plan CEOs, all the major delivery system CEOs, the major physician leaders, consumers, the state, Health and Human Services Secretary, insurance commissioner. We can do this as a petri dish. So that's kind of the vision for what we have for how we plan to take that going forward. I think that's the first time I've taken a breath, so I'm a little lightheaded, so I'll stop there. But if you have ideas for our advisory board, we'd love to hear them. Thank you very much.
All right, so I had teed up a couple of questions for the panelists. In the interest of time, we'll focus on the first question on the slide, and because I think they've addressed to some extent the second question in their presentations, but certainly during the open Q&A, if you want to push it a little further, you're welcome to. So part of the purpose of having health information exchanges is to promote transparency, and I mentioned earlier about the Federal Open Data Initiative, which is all about transparency. And on the other hand, all of us are very concerned about the privacy of patient data and the security of that data. So we have two important values that are in conflict with each other. So I'd like to hear from each of them how your organization tries to balance those two conflicting values. You can flip a coin.
I'll go first, home field advantage.
Okay.
So in Massachusetts, the act that created CHIA was, the title of it included the word transparency. So part of our challenge is to be transparent. And I'll tell you just two stories. One is when I came to CHIA 4 years ago, I said, who's going to be the first payer that requests the APCD? And it wasn't going to be Blue Cross, the largest payer. It was going to be either Tufts or Harvard Pilgrim, because they're the second and third payers. And they would be interested in getting the data. And sure enough, Harvard Pilgrim applied for the data. And we include in our APCD release, submitted, allowed, paid claims. And guess what? The other market participants were not happy. And so we were struck with this idea of base transparency versus proprietary data, contracts, versus patient privacy and security. Well, we address the privacy and security issues by, as I said, we create limited data sets that we make available to the market participants, strip out identifiers, create master patient indexes to protect patient identity while allowing the users of the data to track people over time as they change payers and health plan designs. But the question is, how do we balance transparency? And in the end of the day, we actually released the data to Harvard Pilgrim and now several of the other market participants, be them hospitals and other plans. And the hope is that they use the data to benchmark themselves. And it's not going to be a race to the top in terms of prices, but it'll be a race hopefully to the bottom in terms of prices. But we don't know yet, and it'll be very interesting to see what happens.
So I think by the second slide of my presentation, you've noticed that the legislators in New Hampshire have trumped privacy and security over everything else. And so we are working very diligently with our healthcare organizations, because I think the healthcare side and the patient side understand the value of transparency. We are an opt-out state, so patients do have the ability to opt out of the HIE, but as I mentioned, HIE for us is just, transportation only. So we're trying to sort of get folks to understand that it's one sort of question on how you send your data from point A to point B. It's another, entirely different question to have someone else store it for you. So I think, in terms of transparency and security, we have obviously, like everyone else, all the protections in place for the data we move. It's encrypted, it's secure. We follow all the best practices. It's really just inhibited by that legislative side. So we've got sort of a ground movement, if you will, of healthcare organizations putting together that return on investment story, the patient safety stories, to understand why we need to be more transparent in the movement and the aggregation of data to really support the larger care coordination needs of the patients in New Hampshire.
I probably spend more time on this issue than just about anything else in trying to move things ahead. And we consider it a polarity in which we don't favor one or the other. We've got to advance both at the same time. And so that takes a lot of work with your constituents. It takes a lot of trust building. But we want to change culturally a patient's view of it. We have had the pendulum swing very far to privacy and security in Rhode Island. We are one of the most ratcheted down states in terms of the opt-in. And we've worked a lot with HIPAA and been able to do some other things, but it's still a pretty tight it's a pretty high bar for us. But we want to begin to think about it as getting patient permission to do these things, and consider donating your data like giving blood. It's something that isn't this horrible thing to be avoided under certain circumstances. There's times when doing it is a real humanitarian gift to the rest of us, to everybody else as you expect to hope and help with that. So I think that we can begin to build that cultural concept around that, but at the same time, that notion of intense protection of the privacy and security has to be first and foremost. We too, for me, I just live in fear of a breach all the time, because it would just have reverberate unbelievably in what we're trying to do in Rhode Island. I think there's also another issue of privacy that's going to become more and more a front page, and that's provider privacy. For those of us that rely on the goodwill of our providers to share their data with us, some people have suggested that we become kind of the place where we expose a provider that does this or expose a provider that does that. That's a challenge for an organization like ours, because they could then say, well, if that's going to be the case, I think that my data ought not to flow into current care, because if you're just going to take it and use it against me. So it's another polarity that we really try to balance, is the notion of how I think we're moving far, far away from provider privacy to much, much more transparency. The question is, who uses the data, who makes it transparent? Probably not going to be us, because we are balancing a number of polarities, but it's, it takes up more time and more legal expenses than you can imagine in Rhode Island.
Great. Any questions from anyone out in the audience? Mic is on its way.
Hello, this is a question for Ms. Kramer, and it has to do with the allusion you made in your talk to imputing race and ethnicity data, and I'm very curious about that. I work for Boston Children's Hospital, and I'm on the Diversity Council, and I've also worked a bit with the Boston Public Health Commission as representative of Children's to collect race and ethnicity data on our patients, because we think that's very good for advancing public health for different population groups in Massachusetts. And one of the key parts of that was having patients self-identify their race and ethnicity, because it isn't always obvious from, say, looking at a person or understanding their family history. And so I was wondering how, it seemed to me that if you were doing sort of imputing of race and ethnicity data, you might get a lot of things wrong. And I was wondering how that would work compared to having patients self-report the data and being faithful about recording that data. So on the other hand, I can see if you don't have the data why you'd want to impute, but it seems to me there would be a tension there about getting it right. I was also notice more and more families, both my own extended family and just sort of people that I know, where you've got sort of non-traditional relationships, for example, transracial adoptions, interethnic marriages, where you get some very non-traditional kinds of categories, if you will. And I could think that some of the more interesting information to be gleaned about healthcare and healthcare outcomes would be from these non-traditional kinds of situations rather than from the more standard situations. And I thought that maybe you would lose that information to the extent that you're imputing rather than looking at actual facts. And I'm just wondering if you could comment on that.
Well, okay. So maybe, first of all, it's never Mrs. Kramer. That was my mother-in-law. And I may be worthy of an offline conversation, but so the hospitals, in fact, do a pretty good job at recording race and ethnicity. Many of the people have been trained how to get patient race and to share race and ethnicity. As people developed the APCDs, not only in Massachusetts but around the country, they thought they could get race and ethnicity from payers. And it turns out that even though there might be a place for it on the 837s, it's not needed to adjudicate claims, so the payers don't retain it. And the providers may, in fact, not know, the individual doctor's offices might not know a great job of recording it. So we looked at the race and ethnicity that came in on the payer data. It was very poorly populated, and we wanted to figure out what we could do. So we contracted with RAND, and RAND has published on this, where they take family name and geographic location and calculate the probability that an individual is of the given classes. It is as I shared, it's a probabilistic estimate. It's going to be wrong sometimes. It will not say Marilyn Schlein Kramer, white, 100%. It'll be a probability that they think Marilyn Schlein Kramer is white. It's possible that I am in an interracial relationship and I identify as African American. So what we try to do, so the probabilistic model, then we, in addition to doing it once, we validated it on death certificate data and on mass health data model, because that's actually, those data sets have race and ethnicity very well reported. And it turned out the models did really, really well. They're not perfect, so they'll guess wrong in the instances. And I share your concern that as we create more multicultural families, that those estimates will degrade over time. But right now, they're pretty good. So for population-based, not for understanding a specific patient and their status, but over time, do Hispanics look different than African Americans, that look different than whites? They turn out to be very, very good, and RAND has published widely on that. So we're very excited to be able to think about population, large denominators, and to provide this, and as a way to start looking at the question. Because you're right, it's very hard to get this data and get it accurately at the patient level. I'm happy to talk more offline about it.
Great, thanks. We have time for one more question.
So first of all, thank you for what you guys showed. It's really great to see how the three of you are dealing with this in different ways, and maybe the truth lies in all three of you picking up from each other and bringing it all together. But one thing that I didn't hear, maybe we can talk a little bit more, is really how what you're doing and building feeds into industry innovation. So I'm a small analytics firm. We build models for organizations. We're trying to develop new products to help things in hospitals. How do we make use of what you have to make it better? Because access to data is always the first thing that's the problem. Industry innovation.
For us, it would start with patient permission. We have a lot of innovators that are saying we want to use the data in there, and they're bringing to us groups of patients that are saying we're consented to have our data used that way. With our patient portal, there's a view, download, transmit. You can take the entire record, pull it out of there. For you to be able to use the data de-identified out of current care, come get it, because there's no restrictions on that to use the data de-identified. If you want to use it identified, we have a process that's being developed now through our Rhode Island Department of Health who oversees us. We're a freestanding not-for-profit, so they oversee the use of our data, and so they approve uses of data. Right now, it's primarily research requests that we're getting from Brown and University of Rhode Island and others, but this is an interesting twist that we hadn't thought about, and that commission is meeting soon, and I think we ought to introduce the idea of, is it restricted to research with because they come in with all sorts of other controls on it. Innovation and entrepreneurs do not, but how do we create that path forward? I don't know the answer, but I'm going to take it home, we're going to figure it out.
The Massachusetts APCG is available. You can just go to our website and apply for it.
I would just say, I think, from an innovation standpoint, we're trying to, thinking about not necessarily moving to an aggregated data where you can clean the data and normalize as it comes in. How do we do that in a more federated or distributed model? Can you do it on the fly or sort of on the glass, if you will, sort of solve some of those data security issues, avoid some of the patient consent issues if you can do it kind of on the fly, and that's kind of what we're thinking of in the future.
Great. Well, please join me in thanking our panelists, not just for a great discussion,